When we started in Rwanda, the prevalence was very high. It was around sometimes 11%, 13%. Today, using the DHS Demographic Health Survey, we're about 3%, consecutive DHS survey, where we're doing household data. And if you look very well, women are bearing, the HIV, if you look, women is around 3.6%, and men around 2.2%. And if you look at pediatric HIV prevalence, we're about 0.2%. Now, we moved further to understand who is bearing most of the HIV. As you could see, female sex workers, prevalence of HIV among female sex workers is about 1 out of 2 female sex workers in Rwanda. As opposed to MSM, which they have a prevalence of 4%. So as we can understand, all our targeted that we are trying to do is to focus on those guys who have almost 50% of the HIV prevalence. Looking at incidence, we're about 0.27 per 100 person years, which is also a little high. And men is about 0.21, and women again 0.32. MTCT has decreased from over 10% to 1.5%. I'd like to pause here and congratulate the team here. It was a really great work, making sure that everyone was on treatment, and our ANC PNC is about to exactly have the same number of all women who are attending ANC. And the male circumcision, we are now at 30%. Next slide. Now looking at the death, as you could probably also suspect, before 1994, the genocide against Tutsi, the death and incidence HIV new infections were pretty high. And around 1987, where the infrastructure was not yet there, human resources as well, and as we are moving towards to improve the accessibility, both geographic, finance, and others, we could see barely that incidence is reducing, and up to date, we are almost stabilized, both the incidence and the death. Next slide. Again, as I said before, girls, females, young, have the batch of HIV. So if you look at this pyramid, you could see that girls, so our pyramid is a little bit skewed toward girls, females, and it started when these little girls are around 25, 29, where you see that sharp increase, and to stay again until they get around 50-something. Females are actually also getting, they are living with HIV. We have more female than male in Rwanda. Next slide. So here, we wanted also to share with you our HMIS data, which is Health Management Information System, where we have almost every woman in Rwanda who is pregnant gets access to ANC. So we have almost 100% of ANC, antenatal care. So that's where we had our integration of services, where every single woman who will come for ANC will have access to PMTCT services. As I could see that we have almost the same prevalence as compared to Rwanda, to the general population. And that prevalence is quite now going a little bit down, probably because we are tracking almost all women. There's no really new infection if you look at our HMIs. Next slide. So looking at the female sex workers using our BSS survey of 2015, you could see that these female sex workers, when they're young, we have the prevalence is very high. But this is the next slide, we are comparing to the year of experience. The same girls, the more they are experienced in doing the work, female sex worker, the prevalence goes again high. So you can understand that our 1990s, all our strategies are now targeted and focused instead of just getting everyone into testing. Next slide. Now looking at our 1990 slides, so we have around 88% of people who know the HIV status, and of those who know the HIV status, they are on treatment, 94%. Now going to suppression, viral load suppression, we're about 91%. So which is almost what we want to do, but we want to reach again more. So probably we are going to set our target to 95, maybe 100% at some point. Next slide. So we wanted actually also to compare the adolescents, as you could see in the previous slide, the girls and the adolescents, and to the general population. You could see that there's a difference in the cascade. Again, this is our next focus, to eliminate or to help these girls to get friendly services so they know their status, they get on ART, and also they are viral load suppressed. So those are the strategies that we put in place. Our new approach is case funding for new HIV. So for example, we go to hot spot areas, we test one, and then we ask the person to go get the partners and so forth. By doing that, we think that we are going to have more targeted intervention, but with more efficiencies. So we are going also to expand outreach testing in hotspot, as I said. STI clients referred from pharmacies for testing. Self-testing, we've already started, the oral tests, as well as strengthening linkages to care. Everyone who's tested positive, we definitely put that person to treatment. So we're no longer waiting for CD4 count and stuff. So we've already started since last year the treat all strategy. Next slide. So this slide we wanted actually to show, using again our HMIs, the seropositivity among different groups. As you can tell, that's our histogram. They get more higher when females are about between 15 and 24 years, and it keep on going higher and higher. And the systematic is actually the same from 2015, 16, and 17 HMIs. Next slide. So this one we wanted actually to look at the HIV testing and to focus on VMMC. As you can tell, when we started doing these targeted strategies, our HIV seropositivity went high. Did you notice that? The next paragraph, the next histogram? So that means that we are being more now efficient in terms of targeting those who we want to when we think that they have the highest HIV prevalence. Next slide. So we wanted to share with you how do we work here in Rwanda. We have a map of where we think HIV could lie. So we have the region, as we showed our first slide, where Kigali was almost like 6.3%, where the rest was around 2.6% in terms of prevalence. Also, we mapped all the hotspots, including the truck drivers and others. So we know exactly, if you see the map, the red is actually where we have more HIV, people living with HIV and more female sex workers. And red, so the more we go to the bright color, if I may say, from red to orange, so we know more or less where people are and where HIV can be. That's where we are focusing as well our intervention in terms of testing, but also putting everyone on treatment. And by doing this is actually helping us to again gain, the efficiency and reach the last miles that we need to do. It's more tougher than before. It's hard because that means you deploy a lot of human resources, a lot of strategies, making sure that you link from the testing to the care. Next slide. So our approach, again, as I said, for the next putting everyone on treatment is treat all. We've started also a differentiated service delivery model that my colleague, Dr. Mundo, is going to present in the afternoon, where we are actually spacing. If you're a stable patient, you don't need to come every month for your pill. So we try actually to space that so that the workload on human resources providers, but also the fatigue of the person to come every time if he was already stabilized. So I don't want to go deep in this because Dr. Mundi is going to present that, and what we see as a good approach. 5 minutes. Next slide. So the third one is actually viral load suppression. And again, we are looking at community support, but more importantly, strengthening our viral load monitoring system. So that's what we're doing right now to actually make sure that everyone is being treated and making sure that we are following out also the viral load monitoring. Next slide. So again, this map is again showing us what we did. We also, by just changing the test and treat all, we change also the lab existence, So now we have at all provinces, we have between 1 and 3 lab sites where also we deploy the lab expertise within the region, within the provinces, to also to catch, to do more testing and more viral load testing. So we have between 1 and 3 satellite lab at the provincial level that also will improve our efficiency in terms of viral load testing and others. Next slide. So our final slide is, again, as you know, government of Rwanda is working so hard to accommodate the decline in external funds. As you know, we rely in our government fund, but also in our partners and donors, Global Finance, CDC, and others. And by doing this strategy, we can imagine that it's a lot of human resources, a lot of finance that is going out there, deployment of lab technicians to make sure that we are not delaying any activity. And that will require, again, more resources in mitigating or in reaching the few miles that are remaining. As you could tell, female sex workers are still our target today, given the prevalence, the high prevalence, but also the rest of the key populations like truck drivers and others. And lastly, we are working very hard with our partners in here to target children and adolescents and young adults. Those are in schools, art schools, and create more friendly health services within health facility to make sure that we are also getting these young adolescent adults. So I think this is my last slide. Thank you so much.